Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Asaf Bitton from Ariadne Labs about a call to action, the primary care triple-double. Let's get started. Hello, Dr. Dan. It's still great to see you.
Yes.
And Dr. Bitton, welcome.
Good to see you. Good to see you both.
Very, very good to see you. Earlier today, I was talking with one of our nurses. We work in a value-based care model at City Block, and we work in that space in between the hospital and the primary care practice, or the specialist and the hospital. And she said, we don't bill for what we do. And I said, no, in our world, when prevention works, nothing happens. The people don't get admitted, they don't go to the hospital. And that's why primary care has been underfunded for so long. And I told her that we're going to be speaking with you today, and we're excited to talk about your bold vision to help change that.
It is hard to get people inspired behind a negative or a absence of something, but that is the reality. Though we should also talk about the wonderful things in relationship and good health and flourishing that I do think we create. But you're right. Sometimes the system only cares about what we help avert.
Before we get into talking about healthcare policy and all, most of our listeners are residents, they're medical students, people who are just geeky about value-based care, primary care. I'd love for you to take us into the exam room, and what does primary care look like to you when it's working the way that it ought to be?
Primary care is fundamentally about creating relationships over time. Sometimes the time that you have is one interaction, and other times it's a lifetime. But it's about maintaining these relationships to help walk with people on their journey, wherever they are in their life, in their health. Walk with them to be an advisor, to be a trusted partner in their journey, to give advice when asked, to listen always, to bear witness when there is unavoidable suffering, and to partner with them on what their best days look like. And so that can mean taking a splinter out of a wound. It can mean doing a complex workup of an undifferentiated set of symptoms that will perhaps show cancer, perhaps show a complex autoimmune condition. It means the astute management of complex interacting chronic diseases. It means engaging in rehabilitative care for someone who's recovering from a major injury or a stroke. And then it can be like it was for me yesterday, walking with people in the last miles of their life, and doing that with dignity and with the rings of the tree that have been built over decades, sort of helping them figure out what their best days look like and what their best choices are with what they have left is. So it's a deep privilege. It's all of those things and so much more.
We frequent the AAFP conferences, and when we meet residents, that's especially the family medicine residents, that's what they're really drawn to. It's like the longitudinal relationships.
Yeah. For your listeners that are early in their training, I just have to say, because I tell it to all the residents and students we have in our clinic and in our teaching, what primary care isn't is simple care or rote care or doc-in-a-box care or easily replaced by a computer care. It's not where the not so good med students or nursing students go. It's where the best go, because we're asked to do and to be ready for welcoming and walking with and being the first contact point for over 80 to 90% of what people will have. If we're astute enough to recognize it, if we're ready to be there for them, if we have the IQ and the EQ and the CQ, the community intelligence that we've got to intersect with, then we're doing our job. But that job is most definitely not just titrating blood pressure meds and taking care of sore throats. And we all had some interesting kind of mentors maybe along our way who might have said, "Oh, you're just going into primary care." And I always say, "You're absolutely going into primary care, and you should be proud of that." So I just got to say it to both of you. I know I'm preaching to this choir, but
And I don't know whether it was somebody else called you this or you dubbed yourself this, the primary care cartographer, leading us to the primary care of the future that we need to go to. And I know you've come up with this term for the new year, the triple double. So walk us through that and what the new world will look like if you're the John Smith for primary care. What new world are you taking us to?
Oh boy. Well, I don't know if I dub myself any name. Leave to others to dub the names, and also listen. One of the core features and getting to know you both a little bit over the past year or so, and your excellent work in this incredible podcast. I would say, humility isn't just a nice to have; it's a need to have in our work. So, I don't know if my vision for the future is the vision, but I hope it is. I hope pieces of it are resonant and we can work together to create it. And what it fundamentally boils down to, Dr. Dan, is we in primary care are, a critical part of the healthcare system, and we've got a lot of challenges. And I know you've explored those challenges in other parts of your podcast. But we need to lean past those challenges. We need to name them and recognize them and understand that they're the barriers in our way. But we need to actually sort of transform the way we talk about our profession from we are a nice to have and a charity case, and aren't primary care docs and nurses just so wonderful, and shouldn't we get a little more respect and a couple more cents, to let's have the real discussion from a health policy or health systems organization. If primary care disappeared tomorrow, the health system would collapse. The fact that it's under such threat puts the health system at risk for collapse. The fact that we are not available enough and numerous enough means that our patients in our communities are not getting the care they need. That's not opinion, that's fact. And I'm really into making and illuminating facts for public consumption, whether they be comfortable or uncomfortable. Other parts of the health professions do a really good job articulating their utility case and why they should be supported in both dollars and cents and other ways. We need to do that for primary care because we are the only part of the healthcare system that routinely results in better outcomes at a reasonable or lower cost when you invest in it. There are many important parts of our healthcare system, but primary care is the only part that that statement was true for. In fact, we get better outcomes at a stable or neutral cost with equity when you invest in primary care. Every time I go to listen to health economists or CEO roundtables or health tech folks, they're telling us they need better care at a manageable cost. We have it right here in primary care. We are a must-pass element of the future of the healthcare system. And we are the point where we're finding the most exciting augmentations with technology and AI that actually are resulting in better care for our patients. So if we are to sort of articulate this clear case for primary care, we need to have a fundamental quick go of what are the three things we need to have. And that's where the triple double comes in. Happy to explore it, but I'll stop there.
I think we do want to explore that, but I do want to say when you're talking about those studies that show improved outcomes when you add primary care physicians to the population, the outcomes you're talking about are reduced deaths, right? The ultimate outcome. I mean, you're not talking about patient experience measures, which probably improve, blood pressures or flu shot rates. You're actually talking about more people living longer if they have access to primary care.
Yeah, I mean, was part of a group that did this exact study and a couple of follow-up studies a number of years ago that show very clearly at the county level, Dr. Dan. So not at the state level, because states are big units and lots of stuff happen, but at the county level, controlling for over 25 covariates that include everything from smoking rates and obesity rates to particulate matter in the air, like air pollution, to lots of reasons why mortality rates, poverty, all sorts of reasons mortality rates should be different. And there is an independent and statistically significant and clinically significant effect and association between the density and availability of primary care and population level mortality. So like more primary care means people in that county live longer, and county effects are pretty small size that we're talking about. So there's something going on there. And actually when you discount it and you sort of show, well, or you intermediate, like what's the mechanism? Those mortality drivers are in cardiovascular disease and cancer and substance abuse. All the three main areas where, especially in adult medicine, we help to reduce on a day-by-day basis population level mortality. When you say what is the in other work that's out there, what is the effect on a panel when a PCP leaves? This is wonderful work that's just out. There's an 85% increase in the panel risk of death in the subsequent time period when the PCP leaves. So either you want to look at it by density, by people leaving panels, by adding physicians, you're seeing mortality shifts. There is that fundamental relationship. To my specialist friends, I have some news, which is that though across most of the US, the density and availability of specialty care has increased over the last decade, specialty care density and access is not associated with population level mortality. That doesn't mean we don't love specialists. We do, but we're just talking fundamental health services research science. And so there's something special about primary care, and we need to face that fact in order to then ask ourselves, how can we move forward with the right investment case for it?
Well, let's define the triple double clearly for the listeners.
Yeah. So, this comes a lot of credit where credit's due to my younger daughter, who's a basketball fan. And some of you basketball fans may know this, may have heard of the triple double. So, we were watching our favorite team, and I'm located in the Northeast, so they may be a team in green, and I know that it takes large feelings for some parts of the NBA population. But pick your favorite team, and this wonderful, wise teenage daughter who's a big basketball fan asked me, "Why do these commentators always make a big deal about the triple double? Oh, so and so scored a triple double. She's scoring a triple double. Why is it? What is it?" So a triple double in basketball, for those of you that don't know, is when a player on a team scores in double figure or has in double figures 3 of the 5 major statistical categories in basketball. So double digit points, rebounds, assists, block shots, or steals. Now, her question is really fundamentally important. Why should we care? So I had to look this up, and it turns out, amazingly, that when a team has a player who scores a triple-double, that team wins over 75% of the games. So there's a triple-double is a marker of excellence. So this got me thinking, here we are in primary care, and we have so many needs, and it's so complex, and you all on your podcast have done so much good work on kind of taking apart the complexity and building back a path of, what might we do next? I asked myself, what would be 3 things, not the only 3 things, but 3 things that we could do that might, if you doubled them, actually get us toward improving the lot of primary care so that it can improve the lot of the communities that it serves. And it starts with money, unfortunately or fortunately. And so there are 3 things. And the first double would be that we would double in the next 5 years, and there are ways to do this, the amount of spend that we put toward primary care from 5% currently of total healthcare spend to 10%. That would create the resources to do the next 2 doubles, which are we would double access to what I call the best part of the best part. So if we argue, because of the mortality and other statistics we were just talking about, that primary care is a key, really high performing part of any health system, maybe a best part. What's the best part of the primary care system? Well, one could make a good argument it would be community health centers. Community health centers consistently provide, in decades worth of data, the best care at a population level at the most reasonable price in the most comprehensive way, and some of the best chronic disease care to populations who often are the poorest and most marginalized rural and urban members of our society. So that's, I would call a great investment. So could we double the number of people who get access and are seen by the best part of the best part? From about 10% of the population in the US is taken care of at community health centers to 20%. Now, we can't just put that ask and that burden on community health centers as currently funded, structured, and operated. We'd have to increase massively the number of people working at them, the number of money going into them, the teachings, health center programs, et cetera. So that's a 10% to 20% double. And that helps us get to the third double that we need, which is around workforce. Can we double the proportion of MD and PA graduates who go into and stay in primary care from about 20% to about 40%? So it's three doubles, 5 to 10% on primary care spend, 10 to 20% on access to our wonderful community health centers and keeping that a robust part of our health system, and 20 to 40% in terms of the number of graduates who stay in primary care. We think that there are ways to do that in the next 5 years, and we think that that might be an organizing principle for not all of the things that we do in primary care, but the start of some really good initiatives that we could all as a community get behind.
Well, so money, access, and the workforce.
That's right.
So what would the system look like in 2030 if we achieved this?
Well, first of all, we would see more of the students and trainees that are perhaps listening in this podcast, staying in primary care, seeing it as a viable, exciting, remunerative pathway to pay off their loans. Because as we all know, so many students come in wanting to do primary care. They're like primary care oriented. We have to figure out the ways to give them the permission structure internally and the fiscal structure to do what they always wanted to do, which is to be wonderful primary care clinicians in their communities. So we would see the narrative changing around, oh, you're just doing primary care too? Oh, you're doing primary care. This is so fantastic. And look at all of the amazing things around tech-enabled, team-based, community-oriented care that you think you can build a viable profession on. And so with that infusion of people and with a reduction in hemorrhage of people leaving primary care, either taking down their time or retiring early, we would have then an increase in access that would be buoyed by the increase in money going into primary care to do exactly the things that our communities and our health system executives and our patients are demanding, which is give me access to thoughtful primary care clinicians who are there when I need them. And the only way to do that is with a workforce that's not leaving, that's ready to take care of them, that's got the tools to do it, and that's not on a hamster wheel of fee-for-service visits, so that they have the time, the training, and the wherewithal to meet people where they are and actually provide them excellent care. And then we can do the even more important and exciting things, which once we wean ourselves off of the fee-for-service poison and the inadequate money that goes into primary care to do its always expanding remit, we start to reimagine care as not just who comes to visit me in the clinic, but how can I build a team to meet them in the community, to do more home-based care, to do some wonderful integration with the exciting technologies that allow health to continually be created and understood and data to be transformed and received by ready teams who can then provide advice on that data and really help promote health in all of its dimensions and not on its dimensions of 3 E&M visits a year for 7 minutes at a time. But all of that starts with a workforce that's supported, with the resources that are available, and with students and trainees choosing to do what they wanted to do and seeing a career path in there, and for the more senior clinicians not being burned out every day.
Going back to Frank Lloyd Wright, form follows function. Even if we got the increase in primary care and we increase the number of people having that access, if it's all still driven by producing fee-for-service widgets and maximizing the use of schedules rather than maximizing the relationship, that's going to be pretty difficult to get the outcomes that we're talking about, isn't it?
Completely. Because the fundamental production model, Dr. Dan, wouldn't have been changed. It hasn't been changed. So when we talk to our colleagues and a lot of them say, I don't know, the whole value-based care, team-based care thing, it's just all a bunch of fluffy talk. And tell me why I should actually believe that anything is changing. Well, first of all, that's a really important, good question, and I like hard questions. So let's go at it. Let's go at it, and let's talk about the fact that when we allow ourselves to not sort of ask those questions that you did, Dr. Dan, about did the function change? Are we actually doing anything different? Let's peel the onion layers back. Well, in many value-based contracts, nothing actually changed for primary care. I can say that from personal experience in early and mid value-based days. Because why? Number one, you can't just change the overall contract scheme. It can't just be that the form of the money changed. You got to make sure that the level increased and that increased amount of money in a different way actually flowed to primary care to do the job that it increasingly is being asked to do. In most ACOs, the way it works is that the ACO over here, often hospital-based, signed a contract on risk, total cost of care, maybe upside and downside risk, told primary care to do a bunch of stuff, maybe gave it a few little morsels of extra money, but essentially grades them and follows them on an internal fee-for-service widget that doesn't look any different and doesn't change any of the incentives and maladaptive behaviors that were present before the ACO contract. Is that real value-based care? Absolutely not. The change happens, and I think Dr. Faisel, you see this in your work. The change happens when you actually change the production model, and it's not just talk, but you say, no, our job is to keep you healthy. Primary care is not a cost center. It's actually the value center. You invest in it because we can't have you heading into the hospital for stuff that's preventable. We need smart referrals. We need you to have non-fragmented care because that's the business model here and the health model. When you align those production models, then magic happens. But you got to not pretend that just signing a contract over here and not having things flow down and changing the day-to-day, which actually does mean bust up the schedule. It cannot be fee-for-service treadmill all day long. I mean, I can't tell you how many times I talk to folks and they say, well, we've been trying to do this. And I said, well, how many hours a week do you meet with your team? What do you mean? Well, you have an interdisciplinary team and you guys are responsible for a panel of 6,000 and you have these quality metrics and safety. And then when do you meet? Well, we don't have time to meet. We meet, for 15 minutes over lunch while we're stuffing our face with salad. Okay. But so then you talk to the CFOs and you say, well, why don't you have, Wednesday afternoons, 2 hours a week to meet? I mean, you clearly don't understand productivity targets. I say, you don't understand productivity targets because you're producing the wrong thing. That's the problem here. So I'm laughing, but I'm not kidding.
Yeah, it's a fundamentally different model. I started in community health, but I had one medical assistant. And I had one person who I was with, and I just felt like it was just me and her just trying to do whatever we could do. And then I left from there, same neighborhoods, same communities, but in the value-based care model where we would huddle and have case conference and there'd be a social worker and a behavioral health person and a nurse would come and it's just so different. I couldn't imagine going back to that. And when you're talking about double the spend in primary care, all the things that you're talking about, you didn't mention anything about the doctor salaries. It's all about the support system.
Yeah, most people in primary care, and there are surveys on this, most clinicians in primary care are not asking for more money in primary care to bolster their salaries. They want teams that work. They want colleagues that are not burned out, and they want systems that actually meet their needs and aren't just gigantic billing platforms. I mean, there's a little bit of economic irrationality when you are in primary care, but and we could have that discussion, but that's not the point. I always tell sort of, people that either say this isn't realistic or you're asking for too much. I say, this isn't a greed-based modality here. This is about just demanding the resources necessary to carry out the most critical functions. And I think to your point, Dr. Faisel, the issue has been that we have this strange idiosyncratic historical accident for how we pay for US healthcare. This is not the historical monologue, but so we have this employer-sponsored intermediation, and then we have this unit-based production model that pays for codes and visits and procedures, and it was honestly much, for a large part, kind of a historical idiosyncratic accident. And so we get to a point where people literally say back to you, well, what you're saying is so irrational. You don't understand how the real world works, and this is how things are paid for. And I say, no, you don't understand how the real world works, because that was all a created, misguided journey down. When Medicare needed to figure out a way to contain healthcare spending, it gave a bunch of economists a task to create a unit-based accounting system. And it went into this metastasized process of pretending that it could value equivalently the work of longitudinal relational primary care to taking a cataract out. And that misequilibration led to all of these financial inequities, which led to kind of professional perception inequities and training inequities. And all of a sudden, you basically have a system with 2/3 specialists, 1/3 primary care. And the salaries are all over the place, and the system is not producing what fundamentally the patients tell you it wants it to produce, which is an affordable, accessible, fair system that meets the majority of people's needs where they need it, which is primary care. We love hospitals and specialists, but we can't pretend the reality that we got to this point that has primary care sitting in a corner, starved of resources to do more and more and more in quality and prevention and chronic disease, is somehow a predicated fact and an inevitable reality. It's just an accident, which means we can change it, and we have to change it.
Yeah, we see it in our work, especially community health work. I don't know, I feel like more and more, this is the time for primary care. I couldn't imagine going back. So the idea of the triple double now, I don't think 2030. I think 2030 is too far.
Some people thought it was too close. So but we have to be impatient, and part of the way out of this thicket is, and this is whether you've been doing primary care for 3 months or 30 years, is to look at the issues with fresh eyes, not accept things as being immutable, and not assume that what was will be, and that nothing can change. There's a little cachet of, being cynical somehow has thought people think that's wisdom. It's not. It's actually giving up. Just because it's hard, or because there are forces arrayed, or kind of habits or maladaptive system properties that have caused these things to appear immutable. They are not. And so the first way out of it is to imagine a different future, not in a totally utopian and fanciful fairy tale way, but just to say, does this make any sense? And when people who look like they have, name tags or badges or titles that tell you that, yeah, well, that's just the way it's going to be, and you just kind of have to accept that, you can say, well, hold on a second. Actually, not in this country. I mean, maybe in other places, we have to just accept things as they always are. We can ask hard questions, and we can imagine new futures. And we can not accept the mediocrity of paltry answers. And that's I guess I would just, especially to my colleagues who've been doing this for 30 years and and are yeah, I hear you, but I've seen this show before. I hear you on that too. But that doesn't mean that we have to rewrite it again in the same script. It will change. It has to. The forces making this critical are now, they're squeezed even more than they were 10 years ago. Something will change. Let's try to help catalyze that change for the better.
Dr. Bitton, thank you. Thank you so much for taking the time to join us today. It's just so refreshing. Primary care, but clearly is not the backup plan. It's a strategy. You talked about increasing the investment, the reach, the training with the workforce. You don't just improve the clinics, right? This is how you reshape American healthcare. Thank you so much.
Thank you for having me. Really great to spend time with you.
What are your thoughts on a call to action, the primary care triple double? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.